Hey everyone, welcome to the Basics of CTEPH webinar. I'm Katie Werner. I'm the Community Outreach and Marketing Director at Team Phenomenal Hope. Before we get started, I just wanted to encourage you all to take a look at our full calendar for PH Awareness Month. Would really love for you to take advantage of those resources. So if you use the QR code on our rotating slide deck that we'll have up later during the presentation, you can use that QR code, go to the website and see our full calendar. So with that, I want to go ahead and introduce to you Dr. Christopher King of Inova Fairfax Hospital and Jen Keeley, DNP of Allegheny General Hospital for tonight's presentation.
Thank you so much, Katie, and welcome everybody. It's a pleasure to be here with you and talk a little bit about chronic thromboembolic pulmonary hypertension. Dr. King and I are going to share the slide deck. So I hope everybody has some good take-home messages after this. There will be a brief question and answer period after the slide deck is completed. And I would really, I would encourage everyone to ask the questions that's been on their mind, or if there's a question about one of the slides that we cover. This is how we learn. This is how we, we empower ourselves with knowledge about a disease that we're still really learning a lot about. So with that, let's get started. I'm going to talk to you about chronic thromboembolic pulmonary hypertension. The acronym is called CTEPH. So we'll use that interchangeably throughout the slide deck. When we talk about CTEPH, that's what we're talking about. I'm going to talk to you more specifically about the definition and the diagnosis. As Katie said, I'm an APP, an advanced nurse practitioner in Pittsburgh, Pennsylvania at Allegheny General Hospital. I work in the Pulmonary Vascular Disease Center, the Pulmonary Hypertension Clinic, and I've been doing this for about 15 years, and I really enjoy it. So again, it's really great to be with you all tonight. So here's our initial objectives for this part of the slide deck. First off, I'd like to review the definitions of both pulmonary arterial hypertension and CTEPH. We'll review both the definitions of that. CTEPH is simply a rare form of PAH, and we'll review that in detail. We'll review the classifications of pulmonary arterial hypertension, because that will help us to understand the broad view, this very rare disorder called CTEPH. We'll review symptoms of PAH and CTEPH. And finally, I'll explain to you the techniques of proper diagnosis of CTEPH, which includes invasive and non-invasive testing. And many of you may be familiar with some of these testings. So in terms of the definition, and I want to start off by saying it's a disease of the lung and the heart. So they work synergistically together in this disease. It's a disease of the right side of the heart and the lungs. In pulmonary hypertension, or PH, the blood vessels in the lungs, or the pulmonary arteries, have become very stiff and damaged, or narrowed and constricted over time. And again, the right side of the heart has to work harder to pump blood through the lungs. And as anybody knows, as a weightlifter has to lift weight and pump against a lot of resistance, after a while, his muscles get very, very thick, but he can't keep doing that. So that's exactly what happens in pulmonary hypertension, in that the right side of that heart kind of poops out, if you will. It gets very thick and boggy and incompetent and kind of poops out. CTEPH, or chronic thromboembolic pulmonary hypertension, is then a very rare form of PH. In CTEPH, a thrombus, or a clot-like mass, gets stuck, if you will, to a blood vessel wall in the lungs, and it blocks blood flow. This occurs over a period of time, months or even years in some cases. The clots leave scar tissue embedded in those pulmonary blood vessels, causing further blockage, narrowing, and thickening, particularly in the smaller, more distal vessels. And so you can imagine, we have a lot of these distal vessels in the lungs, how difficult it is to actually improve blood flow to those very small distal vessels. So here's a picture. Hopefully this will help you a bit. It's blown up there in the pulmonary artery, and you can see it almost looks like a balloon type substance, right? And it gets kind of clogged in there. This is much different than an acute embolus, right? This is the aftermath of an acute embolus that has not dissolved on its own. That thrombotic, prolific thickening that occurs in there is very sticky, and it's incredibly difficult for the blood to go through those especially those very small distal arteries. You can see in this picture, the right side of the heart is actually on the left side of your screen. But in particular, that right side of the heart is usually not as thick as the left. In this picture, that right heart is decompensated, and you can tell the walls of that are incredibly thick here. Kind of like a weightlifter, as we talked about, decompensates. His muscles get very thick, but after time, it just decompensates. And so that thickened muscle makes it even harder for that right heart to pump against, fairly high pressures due to this thrombus-like substance that have occluded the pulmonary arteries. So just some key points on pulmonary arterial hypertension. Symptoms are pretty nonspecific because they mimic so many other diseases. In fact, because they are so nonspecific, there's an average of about 12 to 14-month delay from initial presentation to diagnosis. So it's a very difficult disease to diagnose because of that. There is very poor prognosis without therapy and close follow-up. Evaluation should be very methodical and should include a right heart catheterization. Again, I'll talk to you a little bit about that when we talk about imaging studies that we use to diagnose and evaluate this disease. Prognosis improves with therapy, but PAH remains a progressive fatal disease. CTEPH is a little bit unusual because it's the only type of PAH that actually has a cure. And Dr. King will get into that a little bit in terms of evaluation and treatment. Therapies and management strategies continue to evolve over time. It's every day, every week, every month, every year, we're finding new ways to manage this very rare disease. Successful prediction of survival is very crucial in planning therapies, including aggressive medical therapy. Again, Dr. King will get into that a little bit, including transplantation, and with CTEPH surgery or balloon pulmonary artery angioplasty in CTEPH patients. So I wanted to show you this picture because this really is the classification, the gold standard of pulmonary hypertension. About every 5 years, the people that be the very smart people in the world of PH get together at a world symposium. And this was the 6th World Symposium. And they classify or reclassify pulmonary arterial hypertension. And there's about 5 classes now. The first one is pulmonary arterial hypertension due to idiopathic causes. We don't really know what causes this, to be quite honest. Patients develop it for unknown reasons. And there is, along in this group 1, is also heritable. There are definitive genes that we've identified that patients inherit, and this goes into the group 1 as well. Drug-induced pulmonary arterial hypertension from drugs like anorexogens, like fen-phen, you may have heard of that, or weight loss drugs go into this. Methamphetamines, patients that are addicted to methamphetamines oftentimes, unfortunately, develop pulmonary arterial hypertension. Also in this category are connective tissue disease patients, such as rheumatoid patients, lupus, and sclerotic skin disease called scleroderma. HIV patients, a small percentage of HIV patients may develop precapillary pulmonary arterial hypertension. Again, they all belong to this group 1 subset. Congenital heart disease patients also belong here. Group 2 at the bottom of your screen shows PH due to left heart disease. These are our diastolic dysfunction patients, our patients with left heart disease, our patients with valvular disease, our patients with diastolic and systolic dysfunction. I work in the advanced heart failure clinic as well, and this is the most common, actually, type of pulmonary hypertension that we see is that related to group 2. I will tell you that group 2 has no medications that are FDA approved to treat pulmonary hypertension. Definitively group 1, group 2, we have no drugs that are approved to treat group 2 PH. And then we have group 3. These are patients that have intrinsic lung disease, such as COPD, ILD or interstitial lung disease, sleep disordered breathing, and alveolar hyperventilation. We do just recently have been approved for a drug to treat group 3 ILD-based patients or interstitial lung disease, those that have pulmonary fibrosis and other interstitial parenchymal lung diseases. So we're very blessed, and thanks to a lot of research and clinical trials, we do have a medication to treat group 3 lung disease. And again, this is just most recently. And then what we're going to talk about mainly this evening is that group 4 on the bottom left. And you can see at the bottom left, chronic thromboembolic pulmonary hypertension. And we group those into operable or inoperable. Again, Dr. King will talk a little bit more about the candidacy for operable chronic thromboembolic pulmonary hypertension. But again, group 4 is the only group in this classification of pulmonary hypertension that actually has a cure, a surgical cure. So you can see how important it is to get a very efficient, quick workup so that we can treat these patients and get them to centers of excellence so that we can assess their candidacy, if you will, for surgery for a cure for chronic thromboembolic pulmonary hypertension. And then finally, group 5 is kind of all those other disease processes such as sarcoid or other systemic disorders, hematological disorders, those folks that have had a splenectomy and lose their ability to clear blood cells through their spleen. These people kind of fall into that other category, the group 5 category. But tonight, we're going to be talking about group 4, more specifically, the chronic thromboembolic pulmonary hypertension. But I wanted you to see the whole picture of what we call pulmonary hypertension. And you can see that CTEPH is simply just a subset of this 5 classifications of pulmonary hypertension. Again, medications that are FDA approved to treat are the group 1 pulmonary arterial hypertension patients, the group 3 interstitial lung disease, particularly those group 3 patients, and there are medications approved to treat chronic thromboembolic pulmonary hypertension for those patients that are not deemed operable. So I wanted to talk to you a little bit about the histopathology, just to kind of show you a blown up picture, if you will, of the inner lining of an arterial wall and what happens both in PAH and CTEPH. You have just an incredible amount of remodeling and thickening. The smooth muscle inside of the endothelium or inner lining of that artery gets very thick or hypertrophied, if you will. And then that arterial diameter of that artery gets very, very narrowed. And you can imagine how difficult it is for these folks to breathe when they have, just very, very little blood flow going through, almost like breathing through a straw, right? So it's very, very narrowed and causes a lot of symptoms, if you will, for these patients. Just wanted to review a little bit about the vasculature in CTEPH. It's a persistent, so it doesn't go away, right? It doesn't get better. It's a persistent vascular obstruction. Again, you can see on the bottom right corner what that obstruction looks like. And to me, I had a patient that told me it always looks like kind of a meshed up balloon. And when we remove this in the surgery that Dr. King will talk to you about, it is actually like a balloon type substance. It's very thick and sticky and very occlusive, if you will. So there's a vasoconstriction or narrowing of those pulmonary vessels that are occluded in response, leading to a secondary small vessel narrowing distal to that clot. There's some, there's some concept in what came first, the chicken or the egg. Was there distal occlusion first, providing an environment that's very right for clot formation proximal or upstream to that? Or is it the clot indeed that causes this distal occlusion and the obstruction? There's a lot of research being done in that field right now. So because of this vasculature and this narrowing, reductions in pulmonary artery diameter due to the clot and vasoconstriction result in worsening, thickening, fibrosis, and proliferation of accumulation of cells. And of course, this leads to scarring. And when you have scarring, there's not a lot of reversibility. So when we talk about the potential scope of a problem, nearly 600,000 people in the United States actually have an acute pulmonary embolism or clot in their lungs each year. And between 500 and 2,500 new cases of CTEPH are diagnosed yearly. A diagnosis of CTEPH is often not correctly made in patients with PH because they have no overt history of PE. Actually, 75% of CTEPH patients have a history of PE, but a quarter of them do not. So you can imagine how difficult the diagnosis is for those 25% of the patients who don't have a provocative clot, who don't have a history of a clot, so that the provider can actually start to think about what's causing this patient's symptoms. So those 25% of patients, it's very, very difficult to make the diagnosis correctly. As many as 1 out of every 25 patients, or almost 3 to 4% of previously treated patients that have a PE and that are on anticoagulation for greater than 3 months can develop CTEPH. So you can see, 3 to 4% of patients develop CTEPH. So if there's 600 people in the United States that have an acute pulmonary embolus, 3 to 4% of those patients, or roughly 18,000 patients, really have CTEPH. And you can see the incidence is only, according to our registries, between 5 and 2,500. So we have a lot of work to do to identify those patients, right? So we're really behind the 8 ball. So who is it that's actually at risk for developing CTEPH? Patients with blood diseases, patients that have inflammatory diseases, such as lupus or rheumatoid arthritis, certain cancers, such as in particular brain, ovary, pancreas, colon, stomach, lung, and kidney are the most common types of cancers that are very at risk for a clot. Those that I talked to you without a filter or a spleen, those patients that have a very large pulmonary embolism that is unprovoked. Patients that have an infected pacemaker, just the nature of that device and having an infection inside that device causes an environment that's very atherogenic or clot forming. Patients that have blood types A, B, and AB are more at risk for developing CTEPH. Those patients we found that have O-type blood seem to have a little bit of a protective effect. So blood clotting disorders, such as I talked about lupus anticoagulant, those patients that have lupus and have a lupus anticoagulant factor in their blood oftentimes are more at risk for developing CTEPH, and antiphospholipid syndrome. Large clots, which cause significant elevated pulmonary pressures that really have a lot of effect on the pulmonary vascular. These patients are at greater risk for developing CTEPH. So when we talk about development of CTEPH, I want to be perfectly transparent. So you have this patient that has a pulmonary embolus, an acute PE, if you will, and somewhere in between is the gray zone. And then at the other end, there are the patients that actually develop CTEPH. But it's not as black and white as that, right? So patients that don't dissolve their pulmonary embolus for whatever reason don't always develop CTEPH. Sometimes there's this gray area in between, and they develop what we call chronic thromboembolic disease. So they haven't developed high pressures in their lungs yet, but they've developed what we think is this persistent exercise intolerance. how many of those patients that have CTED or chronic persistent exercise intolerance that go on to develop CTEPH is yet to be seen. So I just want to share with you, there's actually a spectrum of the disease. To the left-hand corner, you see an acute clot. That darkened, blackened type of clot is a very acute clot. And Dr. King will show you a little more pictures of those similar to the right-hand picture on this slide. That's actually a dissected pulmonary artery in CTEPH. And you can see it really, does go distally. See those little branches that look like little trees, tree branches coming from that larger clot. Those were all taken and dissected, if you will, from a pulmonary artery. And you can see how distal and small they get. And that's a very difficult procedure to go in and really dissect out that much and get all of it, if you will. So, so it's a really, really impressive surgery. So what kind of symptoms do these patients have? What are we looking for when we diagnose someone with CTEPH? Certainly fatigue, and in particular, those patients that feel short of breath with exercise. Right then and there, I can think of 10 different disease states, that even more than that have fatigue and shortness of breath with exercise associated with them. And one of those is COPD. And unfortunately, we see a lot of patients that have erroneously been diagnosed with COPD over the years. And by the time, they get to us, they've been misdiagnosed and undertreated, if you will, with, pulmonary vasodilators and bronchodilators. And really at this point, their functional status has declined significantly. So it's really important and we really try to really teach, our providers in the surrounding areas to look out for these particular symptoms in patients. Heart palpitations, lightheadedness, chest pain, fainting or syncope. And that's a very ominous sign, because that really means that right heart is pretty decompensated, not really getting enough blood flow at that point when someone actually has a fainting or syncope. Weight gain, it's a disease of the right heart. When we're not pushing blood flow appropriately through the lungs, the blood tends to back up on the right side of the heart. It doesn't really have anywhere else to go except for up into the neck and the chest and the belly, and then down towards the ankles and the feet. And so patients can gain weight very acutely, actually. It can settle in their liver. They can get a very enlarged liver that's actually very painful, a lot of bloating. They can get a cough because of all the fluid that's settled in their chest. And they can get some blood in their cough too, which is actually quite rare and quite latent in the disease. So why in the world is it so difficult to diagnose CTEPH? We talked a little bit about this. It's because these symptoms are so common to other disease states, such as exhaustion, fatigue, shortness of breath on exertion, and these symptoms can be indistinguishable from other forms of severe PH. So part of the diagnosis is actually tweaking out, is this PAH or is this CTEPH? That's a very, very important part of the diagnostic algorithm. And those of you that have been through it understand when I tell you there's a lot of testing that needs to be done. Actually, clue finding, I like to tell my patients, it's like the game of Clue. If it's not this, is it this? So we need different invasive and non-invasive testing to differentiate the disease state of pulmonary hypertension, and then again to differentiate group 1 pulmonary hypertension or group 3 pulmonary hypertension from group 4. So there's a lot of imaging studies that need to be done. Again, we talked about this. Why is it difficult to diagnose? Because some patients don't have that red flag history of having a pulmonary embolus. In fact, as we talked about, 25% of patients do not have a previous pulmonary embolus. And symptoms can certainly be delayed. CTEPH can progress quickly, though some patients may experience what we call a honeymoon period of months to even years between their PE and clinical signs of CTEPH. And that's what I was reviewing on the previous slide. That's that gray area, right? That honeymoon period can be anywhere from months to years when patients actually have that symptom of severe shortness of breath that progresses to actual CTEPH. And then simply the signs of right-sided heart failure actually occur late in the disease process. So those aren't going to be very blatant upfront physical signs until the right heart is actually pretty decompensated. So when to suspect CTEPH? Again, very important, those who have exertional shortness of breath with exercise. So beyond what's normal, right? So beyond running a marathon, beyond deconditioning, those that have severe exertional shortness of breath with exercise, that's fairly unexplained or occurs in the absence of a known clot in your leg or pulmonary embolus. So we start with the initial evaluation of patients with some basic testing. An electrocardiogram can show us signs of an enlarged right heart. It can show us signs of a pulmonary pattern or a lung pattern on the electrocardiogram. So we usually start with a basic electrocardiogram. We get pulmonary function tests, which is a test that looks at the lung volumes and the ability to take oxygen out of the air we breathe and pass it through those tiny capillaries. In those that have pulmonary vascular disease and pulmonary hypertension, that diffusion capacity or the ability to take oxygen out of the air we breathe, pass it through those bronchioles is very diminished. It can also tell us if the patient does indeed have a measure of obstructive pulmonary disease, COPD. It can also tell us if the patient may have interstitial lung disease and more of what we call restrictive pattern on pulmonary function tests. So again, a very important test that most providers and most clinics start out with. And then of course, the chest x-ray. And this is a chest x-ray of a patient with PH. You can see it's a little bit enlarged. You can see the bump about a third of the way down is the pulmonary artery, and that's pretty enlarged. If you would turn this patient from the side, there would be a lack of airspace in between the breastbone or the sternum because the right side of the heart kind of occludes that. So these are, just subtle signs and signs that we see on just basic chest x-rays. A CT scan is often used to rule out lung diseases such as interstitial lung disease, cellular and parenchymal lung disease, right? So these are the rule out kind of imaging studies. We want to rule out group 3 and rule in group 4 if we can. So this is just a little acronym that I use, and I think it's pretty straightforward. We suspect CTEPH and PAH by getting an echocardiogram and a VQ scan, and I'll talk to you a little bit about that in just a moment. We confirm, and this is so important because we can't diagnose PAH or CTEPH without confirmation through a right heart catheterization. You can screen for it and suspect it through an echocardiogram, but you must have a confirmation right heart catheterization. So that's really an important concept to take home with you tonight. It's very, very important. Confirmation must come from a right heart catheterization. And then there's a pulmonary angiogram that shoots dye in to look at the pulmonary arteries and the pulmonary vascularity. And it's a really cool test. You can see, I'll show you a picture of it, but it helps actually it helps us to look at that and decide if the patient, how much of CTEPH the patient has, the degree of CTEPH that the patient has. Is the disease very distal? Is this patient going to be a good candidate for surgery called a pulmonary thromboembolic? So it helps guide surgical candidacy, if you will. And then finally, we assess the risk through hemodynamics and we send the patient to a surgical team that has good CTEPH team experience. And that's really important. So there's no dilly-dallying in this disease, right? These patients need to get to a center that actually participates in the candidacy of CTEPH and pulmonary endarterectomies. And you know, the sooner that they get there, the sooner they can actually understand their candidacy for the disease. If they are not a candidate, Dr. King will talk a little bit more about this. There is some medical therapy that is approved. So here's an echo. You may or may not be familiar with it. On the left-hand side, there's a normal slide. Again, the right side of the heart is on the left side of your screen, and the left side of the heart is on the right side of your screen. The purple arrows show the right side of the heart. And the normal side, you can see there, the right side of the heart is actually a little bit smaller than the left side. It looks good. The top chambers of the heart look good. And then on the pH side, you can see the incredible thickening of the right side of the heart, as we saw in the initial picture that I showed you, and really the dilatation and the decompensation that's occurred. Actually, the right side of the heart is so big, it's actually impinging. You can see on that little left side of the heart. So that strong left ventricle has now become a very tiny, weakened left ventricle. And these patients are very sick. They develop, you know, fulminant left-sided heart failure as well. So for some people, you know, again, it can take, you know, months to years to develop this, sometimes more acutely to develop this. There's an echo machine there to the right. So it certainly is a screening test of choice for patients because it's non-invasive, right? It can be done portably. It looks at the right heart chambers. It looks to see if the right side of the ventricle is dysfunctional, particularly after a pulmonary embolus, right? That can certainly affect the right side of the heart. It looks for backflow of blood when the heart pumps, and it can estimate. It can't directly measure. I want to make that very important point. It will not directly measure the pulmonary pressures, but it will estimate them. Again, the echo alone cannot diagnose CTEPH. It can determine if you have some type of pulmonary hypertension. If results of your echo do suggest pulmonary hypertension, the providers will perform additional tests, as we talked about, to look for other causes of PH. So this is what's called a ventilation perfusion scan. And it is a scan, it's the preferred method after an echocardiogram to rule in or rule out CTEPH. There's a lot of validity in this test, and we use this over a test called a CT angiogram. So it's called a VQ scan, standing for a ventilation perfusion scan. It reveals areas in the lung that are not receiving blood as expected when you breathe. Two tests make up the scan: a ventilation or breathing scan, and then a perfusion scan looking for the blood flow movement through the lungs. During the ventilation scan, you'll inhale a radioactive gas. It doesn't really have a taste to it. It may make you cough through a mask while lying under a scanner. During the perfusion scan, the doctor injects a special solution that lights up into your veins and places you on a movable table under the scanner. The scanner allows them to see how well, again, the blood flow is moving through the lungs. On the top portion of this, you can see the ventilation portion. And this patient obviously has some inherent lung disease. But the most important thing that we're looking on this is there a mismatch between the top ventilation portion and the perfusion portion? On the bottom left side of this VQ scan, you can see the whole right side of the lung is actually missing. So that's the perfusion scan. And if you look at the top portion, you can see that right lung is there on the ventilation portion. So there's a very mismatched perfusion deficit here on this VQ scan. This patient definitively has a measure of CTEPH. So again, that ventilation perfusion scan, a very important, validated and sensitive test to rule in or rule out CTEPH, and it must be done. From there, we go on to measure the pulmonary pressures by right heart catheterization. It's required to confirm the diagnosis. And again, it allows your doctor to directly measure the pressures in your heart and lungs. It lets the doctors know how well your heart is actually pumping, your cardiac output. And it allows them to see how well you're oxygenating as well. Some of you may have undergone 1, 2, or several right heart catheterizations. There's several ways that they can enter. The basilic vein, which is in your arm, the femoral vein, which is in your groin, but most often they enter through the jugular vein on either side. And this is the pulmonary angiogram, which is done. You can see what a great picture that lights up all of the pulmonary vasculature, even the most distal vessels, and it helps to let the provider see what exactly and where the blood perfusion deficits actually are. So this is usually done after the VQ scan and then confirmation of pulmonary pressures by right heart catheterization. So this will actually help determine candidacy if the patient has CTEPH and what degree of CTEPH that they have. Again, patients that have a lot of very distal disease, it's very hard to get to those very distal vessels, and Dr. King can talk to you a little bit more about that. So I'm going to actually turn it over to him now. He's going to talk to you about the treatment of CTEPH. And then again, just to remind you afterwards, would love to take questions from you about anything that we talked about or anything that's on your mind about CTEPH.
Hey everybody, I'm Chris King. I'm one of the pulmonary hypertension doctors at Inova Fairfax Hospital in Falls Church, Virginia. So thanks, Jennifer. That was a great introduction to CTEPH. And we're going to focus more on the treatment in my section. So our objectives, we'll go over the treatments available for CTEPH and understand kind of how we go about deciding what treatment's right for an individual patient. So just a quick case, this is a pretty typical patient. We might see a 56-year-old male, no known history of blood clots. He has a history of high blood pressure, high cholesterol. He's never had a prior surgery. He's just on some cholesterol medicine, aspirin and lisinopril, which is a blood pressure medication. Family history of blood clots. He's not a smoker. He's married, works as an accountant, had progressive shortness of breath for about a year, and he saw his primary care doctor. They did a chest x-ray that didn't really show anything. He was given an inhaler for asthma with no improvement. And as Jennifer mentioned, that's a pretty common scenario we see in patients that are diagnosed with pulmonary hypertension. There's usually a substantial delay, and they see multiple physicians before they get the correct diagnosis and move on. So this patient gets referred to a pulmonologist who gets an echo that suggests pulmonary hypertension. And in any patient that's diagnosed with pulmonary hypertension, they need a right heart catheterization at some point to sort of figure out, what kind of pulmonary hypertension they have. And in patients with, what we call kind of pre-capillary pulmonary hypertension, meaning some issue with the blood vessels, they should be evaluated to see if there's evidence of chronic thromboembolic pulmonary hypertension. And the test that's usually done to establish that is a VQ scan, which is that nuclear medicine scan that was mentioned earlier. And so this person gets a VQ scan, and it shows, really diminished perfusion on on one of the lungs, and it's consistent with CTEPH. And so now what do you do? Like, where do you go from there? And so this is a common thing that we're faced with in clinic. And I think, Jennifer was exactly right when she said, you really need to get to a center with expertise in evaluation and treatment of CTEPH. It's, a lot of times people that could potentially have a surgery that would, has the potential to substantially improve or cure their pulmonary hypertension are denied that at inexperienced centers because they feel like the clots aren't close enough in, that surgery is not a good option for them, or they're just put on medications, and just kind of left at that point. And they don't get appropriate follow-up, appropriate counseling, and don't get the right treatment for them. And so, as Jennifer mentioned, there's quite a few tests that we'll do in patients that have CTEPH. Why do we do all this testing? First we need to establish the diagnosis. We really need to know that CTEPH is what's going on and what's causing the symptoms, and that the blood clots that are seen are chronic, not acute. We need to know how extensive they are, where they affect the perfusion of the lung, because the location of the clots may dictate whether the person is a candidate for surgery or not. We also need to know what the pressures in the lungs are, what kind of risk they have of undergoing surgery, what kind of benefit the person stands to gain from having surgery. And you also want to match the clots up with the change in pressure that you're seeing, and make sure that it seems like the clots are responsible for the pulmonary hypertension. Other things you're evaluating for: is there evidence of other underlying lung disease, because that may affect candidacy for surgery, and then figure out if the person's an appropriate candidate for surgery. There's a little bit of testing that goes into that as well. So this is the 5th World Symposium on Pulmonary Hypertension. They had an algorithm for CTEPH, and so once you get a diagnosis, everyone should be on lifelong anticoagulation that has CTEPH, barring some significant bleeding complication that precludes doing it safely. We had a patient here that was a professional boxer, and he had CTEPH, had an operation, got much better, actually went back to boxing, but because of that, he was unwilling to take his anticoagulation, and his clots all came back, and he had to have a second operation at another center, and didn't get a complete resolution, and was left with enough symptoms that he couldn't really go back to boxing again. And so, if you don't take anticoagulation for these conditions, they will recur. And then you want to make that determination if the person's operable or not. And generally, if a person has operable disease, that's the preferred strategy, assuming that they're an appropriate candidate for surgery. That gives you the largest decrease in the resistance in the lungs from the blood clots, and the best chance for an appropriate outcome and a good outcome. If the person's deemed non-operable, there are some other things that you can do. One thing would be get a second opinion from an experienced center. Oftentimes, San Diego is the place that people look to because they're the most experienced center in the United States. And so if a CTEPH center that has a lower volume, doesn't think it's a great idea, and the patient's interested in a second opinion, or if the clinicians aren't sure, they may reach out to that more experienced center just to get another set of eyes on their testing and see what the best approach is thought to be. And then if the person's not a candidate for surgery, there's a couple other options. One would be this balloon procedure called balloon pulmonary angioplasty, which I'll mention, or medications that can reduce the pressure in the lungs, or a combination of those two things. And that's typically what you see in patients that are going down that non-operable route, is that they get at a minimum medications, and then if they're going to get balloon pulmonary angioplasty, they're on medications beforehand, and then depending on the response, potentially after. So I mentioned pulmonary thromboembolic, which is the name for the surgery that's done. And so it's an open heart surgery. It is a significant surgery where you go on cardiopulmonary bypass. You get an incision on your sternum. They cool patients down really low. There's a special way they do anesthesia, and the surgeon will go in and kind of start in the closer in, like more proximal portion of the pulmonary artery, and try and find the clot, and then they pull it out. Our surgeon described it as if there's like a string on a sweater, when you start, that's unraveling, you start pulling it, that you can kind of find this plane and unravel and pull the clot out, and then try and track that out as far as you can to the more distal vessels. If there's a lot of disease on the edge of the lung, some of that clot may not be able to come out. And so it's not always a curative procedure. Some patients are left, depending on the amount of disease they have sort of distal in the lung and how well the surgery goes. Some patients may still require that balloon procedure down the line, or they may require medications for pulmonary hypertension afterwards. However, again, survival overall seems to be better, about 89% 3-year survival with surgery versus 70% with medical therapy. So how do you know who's operable? Again, you should always be thinking about whether the person's a surgical candidate, and the things that you're considering, is the clot close enough in to be accessible by surgery? And I have some examples, and I'll show you, what the surgeons can get to. Again, is this clot responsible for the increase in the pulmonary pressures we're seeing? If you see just one little tiny clot kind of on the edge of the lung, but really high pressures, then that's not CTEPH that's driving those pulmonary pressures. And doing a surgery is probably going to make the person worse. And so something that you need to think about, and you need to evaluate for other causes of pulmonary hypertension. And then, can the person tolerate the procedure? Are they really debilitated? Do they have other substantial comorbidities? Do they have significant underlying interstitial lung disease or COPD that's going to cause a problem at the time of surgery? And sometimes in those cases, the person, even if the clot would be okay to do surgery on, or their hemodynamics match up, we may say, we don't think surgery is a great idea. So, again, is the clot accessible by surgery? We traditionally, I think historically, really kind of close in proximal clots in the main pulmonary artery, what was being operated on and offered surgery. However, we know that other disease can be operated on. And so these are, the different types or the kind of a grading system that the surgeons use. And so major blood vessels, this would match up with the CT scan I just showed you. So it's in the main pulmonary artery, this type 1 disease, definitely can operate on that. Now, what about type 2? So you get a little further out into, like, you have 3 lobes. So lobar is kind of the first division, and then from there there's segments in the lung. So that's kind of that second order of blood vessels. That's type 2 disease, and you can operate on that as well. Type 3 disease is where you get out past the segments and into more of these subsegments, and that can even be operated on. And it's when you get really, really far out on the edge of the lung in these intrinsic small vessels, what they call type 4 disease. Generally, that's not operated on. And so, because if you go in and somebody has really high pressures, you subject them to cardiopulmonary bypass, their right ventricle sick, and then you're not able to bring their pressures down. Those are the patients that do poorly after the surgery. So, again, it's a relatively safe operation with appropriate candidate selection. Some older data from UCSD, they quoted a 2% in-hospital mortality with the surgery. If I had to guess, I would say it may even be lower today. There's about 4.7% in European centers of excellence. I think we're getting better and better at some of the rescue strategies, like extracorporeal support that you can use, which means like you can kind of put people in a heart-lung machine for complications after these procedures. And I think we're getting better and better at the operation and better at selecting appropriate candidates for the surgery. And some patients that maybe historically they would have tried surgery on, now that we have this balloon procedure, I think maybe you don't push your luck so much. And so I do think, the success rate is higher and higher. There are some risk factors, for poor outcome. Having coronary artery disease, so blockages in your heart blood vessels, increases your risk of dying in the hospital after the surgery, although it's not like an absolute contraindication to having surgery done. And the main thing that dictates whether patients do well or not is, how much do you decrease the pressure in their lungs. So PVR is something called pulmonary vascular resistance. And so that right heart catheterization test will tell you what your pulmonary vascular resistance is. And patients with a very high one, that's not necessarily a contraindication. You just need to see that number come down And so if you go in and you don't get a good result, the resistance doesn't go down, those patients have about a 1 in 10 chance of dying in the hospital, as opposed to patients that get an adequate hemodynamic response. Some of the things like having prior surgeries, being tall, being obese, don't really affect your mortality or risk of dying with the procedure. Older age increases the time it takes to recover from the surgery and your time of that people spend in the hospital, but the risk of dying is not necessarily any higher. So I think thing to highlight, if you're operable and an appropriate candidate, surgery is really the recommended strategy. So what about if you're not? So there's a procedure called balloon pulmonary angioplasty, and Jennifer mentioned these clots that you get in chronic thromboembolic disease aren't like clots that are acute. Acute clots with anticoagulation, your body can kind of chew those up and get rid of them over time. But I always describe it as almost like a scar, and your body can't kind of get inside that scar and break the clot up. And so if you have somebody who has those kind of clots, you can do this balloon procedure where you go in almost the same way you would with a right heart catheterization, and they blow up these balloons, and they can kind of disrupt the clot enough that your body can start to get in there and chew the clot up and start to get rid of it. And so you can use that for patients that have kind of distal inoperable disease, or if they have disease that's left over after a surgery, or patients that are poor surgical candidates. I will say in some places, like in Japan, they don't really do the surgery. They do balloon pulmonary angioplasty for everyone. So whether that'll be a change we see over time or not, I'm not sure. We'll have to see how things evolve over time. Now, this is something that, it's not a single procedure. You don't just have this done once. You can't go too crazy dilating the blood vessels right away, or you can cause a rupture and you can cause bleeding and can be kind of a big deal and can cause death or cause, prolonged hospitalization. And so you have to be sort of gentle and bring people back for multiple sessions, a lot of times somewhere between 6 and 8 sessions separated over time. And over time, as you do those serial sessions of this balloon procedure, you can bring the pressures in the lungs down. And so this is a picture pulmonary angiogram. So they're squirting dye in here, and you can see there should be all these blood vessels here, but you don't really see them. And so they go in, and then this is the balloon blowing up. And then they shoot dye in again after the balloon is deflated, and you can see you get nice kind of improved blood flow downstream from where the balloon went in. There's a lower mortality. It's not a 0% mortality associated with this procedure because, again, there's some risk of rupture. There's some risk for reperfusion injury. And reperfusion means like as the blood flow is restored to those areas that didn't see it before, the lung can get kind of boggy and make your oxygen level go down. But overall, relatively safe procedure and can be effective if you select the appropriate candidates. You can also use medicines that bring the pressures in the lungs down. And so, they don't really affect the areas where the clots are, but you get sort of release of evil humors in the lung and the other compartment without the clots. And that can lead to increases in the pulmonary vascular resistance. And so by giving those medicines, you can bring the pressures down and decrease the strain that the right ventricle is on when it's pumping against because it's pumping against less pressure. We also use medicines to sort of help people pee off more fluid, and that can shrink the right side of the heart down and help it squeeze better. And so medical therapy is an option. This is a trial that was done on Adempas or riociguat, which is the primary medication that's used because it's the only one that's currently FDA approved for use in CTEPH. And they looked at 260 patients with CTEPH that was inoperable or persistent after they had surgery. And they looked at how far they could walk during a 6-minute walk test. And the group that got riociguat was able to walk substantially farther than the group that just got placebo. And so that led to approval of this medication. They also saw that the pulmonary vascular resistance went down a marker that we look at for the amount of stretch in the heart called pro-BNP went down, and patients' functional class, meaning like how far you could walk and how short of breath you are when you're walking, improved. There's another study called the Merit trial looking at a different medication, and it also showed efficacy in decreasing the resistance in the lung. I don't think it matters too much which medication you use. Again, most people use Adempas kind of first line. I think they were smart enough to do the study in this population, which hadn't really been well studied before. And so they got the approval. But if you have a patient that has side effects with that particular medication, or it's like prohibitively expensive or something, there's other medications that you can use and can still be effective. I mentioned combination therapy earlier, where you combine that balloon procedure with medications, and that's a possibility as well. And so, there was a study called the RACE trial where they did either the riociguat medication to bring the pressure down or the balloon procedure up front, and they found that if you treated patients with riociguat up front, they had less adverse events, but the drop in the pressures in the lungs was lower with BPA. The group that sort of did the best, because you could cross people over from one group to the other, were patients that got riociguat first, brought their pressure down. It reduces the number of complications you have during the balloon procedure, and then did the balloon procedure. And so oftentimes that's the way that most people approach this disease in non-surgical candidates. And so kind of conclusions for me is that anybody with CTEPH should really be evaluated at CTEPH center to see, to make a plan about what the best treatment to offer them is. Treatment options include surgery, the balloon procedure, or medications, or some combination of those treatments. And so I think that concludes the lecture part. I think we're about a minute over. Sorry about that. I believe we are open to questions in the chat box if anybody has any questions.
How do patients know where CTEPH centers are located? So great question. On the Pulmonary Hypertension Association website, there are centers that are called CCC centers, comprehensive care centers that are accredited. And these CCC centers are centers of excellence for CTEPH, and they are listed on the PHA website.
I will point out, like, not every PAH center is a CTEPH center. There's a number of centers, and so you might inquire if that center does CTEPH. But in general, if you can get to an accredited accredited PH center, they should have a pathway in place to get you to a CTEPH center to be evaluated. That's something that pulmonary hypertension, accredited pulmonary hypertension programs are familiar with, and they generally have, if they're not a center that takes care of CTEPH patients, then they should be able to get you to one.
And then there's another question. Is it recommended for people diagnosed with PH to have VQ scans every few years to be sure that PEs are not developing or redeveloping? And yes, we do. There is a practice that, if we feel that the pulmonary vascular, the PVR, the pulmonary vascular pressures have gone up or are very labile, and there's been, some time in between the VQ scan, some hospitalizations, some different comorbid conditions such as, pneumonia, COVID, motor vehicle accident, what have you, then it's very important to do another ventilation perfusion scan to assess for any CTEPH that may have redeveloped or developed. Mm-hmm.
I think there was just one other question from Vanessa. It says, what about having PAH and clots showing up after diagnosis and a couple of years into treatment?
You certainly, patients with PH can get blood clots, after their initial diagnosis. It's important to do a scan early on to look. A lot of times, I think people miss that early in their diagnosis. There are a number of patients, like some things are shared risk factors, things like splenectomy, can set you up for CTEPH, but can also lead to pulmonary hypertension. And so, some patients, unfortunately, not all pulmonary hypertension patients like fit neatly into one single category. I have a number of patients where, they have some pulmonary arterial hypertension, but they also have maybe a small clot. And so that's why it's important to sort of put the, kind of contextualize the degree of the elevation and the pressures with the extent of the clot burden. Not everyone, so you can have pulmonary arterial hypertension, have an abnormal VQ scan, and not sort of have classic CTEPH and not need surgery or a balloon procedure, but it's something that needs to be looked into oftentimes.
Yeah, that's for sure. I can think of an example. Sickle cell patients oftentimes, develop pulmonary hypertension, and they get a lot of blood transfusions, exchange transfusions for their sickle cell. And so a lot of them have indwelling ports in. And so they may develop, group 5 due to sickle cell disease, group 5 PH, but they also may, because of the incredible amount of exchange transfusions that they receive, develop clots around that port, or when the ports get infected. Again, that was a quality that we talked about that raises the risk for CTEPH. So it's very important. These are really great questions because it raises the point that it's not one and done a lot of times. You have to reassess and reassess. And that's why, right heart catheterizations are usually done on a biannual or annual basis to look for, any worsening of the pH.
Dr. King, Jen, thank you so much for your time tonight. This presentation was so valuable. I know that everyone who attended really appreciated it. So, and thanks for taking the time to answer questions as well. So before we close out, just wanted to encourage you all to take a look at our pH Awareness Month schedule using the QR code that's on the rotating slides. Also want to take a minute to thank our sponsors for helping us be able to do this tonight as well. So you guys, everyone take care. Thanks so much for your time. Have a good night.